Welcome, everyone. I have a special topic today and a special guest. I know that we oftentimes will focus a lot on the clinical side of rehabilitation, predominantly physical therapy. But on this episode of the Strength and Knowledge podcast, I'm very, very excited to bring to you somebody that is focused a lot more on the business side of rehabilitation, of physical therapy in particular. Rick Gawenda. Rick, thank you so much for joining us today. I really appreciate it.
Thanks, Josh. Appreciate you having me. Looking forward to the discussion here.
Absolutely. So, you started out in a very, very different space, and with regards to where you're focusing a lot of your time now on the business side of things, both with Gawenda seminars and then being a little bit more involved, at least from my familiarity, in a newer group that's involved in mergers and acquisitions. Can you share a little bit just kind of your trajectory and what kind of your path has been to where you are today?
Sure. So I'm one of those old school physical therapists. I graduated in 1991. So coming up this fall, it'll be 30 years. And again, just with a bachelor's back in 1991, kind of grew up in the hospital setting as a staff therapist, then into a supervisory role. Then went to a different hospital and became director of the rehab department, and then more into hospital management administration, where I oversaw other departments besides physical occupational speech therapy. Before I became director in hospital management, the first hospital I was kind of at, the therapy department ended up on a 100% Medicare review for outpatient therapy. And this was probably back in 1998, 1999. And kind of at the time, my director didn't know what to do. The finance department didn't know what to do, et cetera. So I don't remember if I kind of volunteered to learn or if the director asked me if I wanted to do it. So anyhow, kind of got into that. Took about 18 months to get the hospital off the 100% review, but kind of fell in love with it. And then, back in the early 2000s, listservs were becoming very popular. So I was a member of the APTA in the Michigan chapter. That's where I was born and raised. And then just kind of, in the first couple of years, maybe the first year or so, just kind of lurked on the listservs, just kind of soaked in all the information, and then kind of started to answer people's questions one by one. And then apparently somebody thought I was smart, asked me if I wanted to speak and come and do a talk. And then it led to a book deal, and then just kind of took off from there. Really got involved with the section on health policy and administration of the APTA. Ended up being president of that section for 6 years. Was president of an association in the state of Michigan, the Michigan kind of rehab hospital network there, and just kind of took off, and then started Gawenda seminars and consulting back in 2003. So from 2003 until Christmas of 2009, worked in hospital administration. But then on the weekends, I would go around the country, doing live speaking engagements or consulting for hospitals, private practices. And then just finally left the hospital on Christmas 2009. And for about the last 12 years now, Gawenda seminars and consulting focuses just on outpatient PT, OT speech in terms of documentation, coding, billing, compliance. Also do legal work where most times I'm retained by attorneys on the defendant side, representing the therapists. As you alluded to, about a year or so ago, kind of became partners with another group called Premier Rehab Group, PRG, where we bring clinics together in a state. We kind of bring them together, try to get them on the same platform in terms of electronic medical record system, financial reporting systems, maybe HR systems. And then once we have that together all in one, we take it, quote, to market to some of these bigger therapy clinics, therapy chains, or private equity groups that are interested in purchasing them. So instead of being an individual clinic where you may only get a 1 or 2 multiple, by joining with us and kind of combining a bunch of clinics together, we can create a kind of a higher net income, what we call EBITDA. And maybe you can get a 6, 7 multiple or even higher than that. So we're doing that right now in California, Texas, and Louisiana. We've combined, and also in the state of Florida.
That's awesome. And I definitely want to dive into that because I think that's something that people would honestly just benefit from hearing. Out of curiosity, have you always had a tug in terms of your entrepreneurial spirit? Is this just more you recognizing strengths with regards to just viewing things a little bit more analytically? I mean, what kind of pushed you in this direction?
Yeah, it's kind of funny. You know, I'm not sure how your audience would take this next statement, but obviously being a Christian, sometimes I want to do one thing and you kind of hear God laughing. I went into physical therapy school to really do athletes, work with sports and all of that. And believe it or not, I never did what I went to school for. I never got the opportunity to work with athletes, whether it be high school, college, or professional. I said I would never go into management. Went into management. I said I would never write a book. I've been blessed to write 2 books. So, I think it's just the path. I think as one door shut, another door opened. And I think I just had the discernment to go through the door and see what was there for me. I also think I had other people probably believe in me more than I believed in myself at that time, and saw things in me that I did not see in myself. I never imagined I'd be president of a section of the American Physical Therapy Association, or president of a group of rehab professionals in the state of Michigan. It's just, I think others saw something in me and then mentored me to get to that position.
Yeah, and I think, admittedly, I feel a little bit of a pull in that direction. Granted, I'm in a different stage of my career, and your accomplishments obviously are lengthy at this point. But I was just curious, honestly, just finding myself moving from clinician to being a little bit more focused on business. That being said, I also feel like sometimes business is a 4-letter word when it comes to healthcare, and especially PT. But I'm at least an advocate for people, even if they don't want to go into business, having a little bit more business literacy and just baseline competencies surrounding what should get measured or what matters when it comes to more objective markers. When people hear objective metrics, they're automatically thinking of productivity metrics, but I'm familiar, obviously, that there's a lot more that we can be looking at when it comes to things that go on business-wise that tell us whether or not we're doing things the right way, or whether or not there's a certain health associated with the business. Outside of productivity, what are some things that you find yourself discussing or having conversations about the most with either young business owners or even the most experienced business owners?
Yeah. And again, whether you are a business owner or not, if you may just be a staff therapist in a practice, a staff therapist in a hospital setting, et cetera, the one thing I really want to stress is, make sure you understand your state practice act. Make sure you do understand the rules and regulations of the different insurance carriers, because ultimately it is your responsibility. And if something is done wrong and you're part of that, the one thing I will say is you will go down with the organization, you will go down with the practice. So I think that's one of the biggest things before we get to answer your question is, young therapists, even senior therapists think, well, the owner will take care of that, or the owner will tell me, or the director will tell me. And doing the legal work that I do, I see so many times that these staff therapists are being sanctioned by their state licensing board or insurance companies, or worse yet, the Office of the Inspector General, and we're going to federal court. And the statement of, well, I thought my boss was taking care of it, doesn't work. Now, to answer your question about metrics, obviously productivity is important. And, I think a lot of business owners, they look at units per visit, they look at visits per 8-hour day and things like that. And somebody may think, hey, we're averaging, 9.74 visits per 8-hour day. We're averaging 3.76 units per day. We should be making money. I think they need to look at other things. I think you need to be able to look at, well, what CPT codes are you billing? So yes, you're averaging 3.76 units per visit, but are one of those units, a hot and cold pack that pays nothing? Is it mechanical traction, unattended e-stim that pays, $12, $13, et cetera? So I think, every month, why not print out a list of all the CPT codes billed that month? What percentage of them are what I call the quality codes, therapeutic exercise, therapeutic activities, neuro-rehab, versus what I'll call the modality codes that don't pay a whole heck of a lot. I think a lot of people look at cancel no-show rate. Well, what we like to look at is what we call arrival rate, because cancel no-show rate can be deceiving. So let's just say, Josh, you're scheduled to come in Monday, Wednesday, Friday. Well, on Wednesday morning, you call and you cancel, but they reschedule you for Thursday. And now you come in Monday, Thursday, Friday. Well, many clinics will, since you called Wednesday, will count that as a cancel, even though you did come in 3 times that week, like you were supposed to. So what we look at is arrival rate. So what we do is at the end of a workday, so let's say we're closing at 5 o'clock today, at about 4:45, our front office people are going to add up all the appointments that are scheduled for tomorrow. Let's just say, do easy math, it's 50. Okay, so tomorrow comes. How many of those 50 people showed up? And let's say 47 of 50 showed up. We have a 94% arrival rate. Also, it's possible to be above 100% because you might have all 50 show up, but then a patient may call or a doctor may call, ask a favor to get somebody in. Could you be 51 out of 50, 52 out of 50? So we look at that. And, in the clinics that we're in, we try to go 90% or better arrival rate. And, obviously you can make incentives, for your front office staff to achieve that goal. You can make incentives for the therapists and assistants, to help achieve that goal. So I think that's a big one. Obviously patient satisfaction, I think is extremely important. And I think that's something we don't do very well. I'm sure, Josh, you hear it all the time. You especially in private practices, well, my patients love me. We get our patients better. They do great. But we don't have the data to show that your patients love you, that we do great. So when you're trying to go to insurance carrier to get more money per visit or more money per CPT code, we don't have that outcome data that shows not only our satisfaction scores, but maybe those outcome measurement tools, and that we can get people better in 7.62 visits, where maybe other clinics are averaging 11.3. So if you have that data, can you then help maybe leverage to try to get more money because you're actually doing it in less visits? So those are some things. I mean, this could be a whole talk by itself, of course, on what we can look at.
Yeah, I mean, I'm just curious, is some of that a byproduct of just people not knowing that it matters? Is it the documentation systems that they're using? I mean, like, for example, we use WebPT. So when we're doing our outcomes reports, we're naturally getting these touch points at an initial evaluation, a progress note, discharge, along with pain, goals met, right? And then the whether or not it's the LEFS or the back disability index. So there are things that I think are naturally in front of us with the documentation system that we chose. Do you have any thoughts there?
Again, I think some of it can be documentation system if you're using one that maybe is not specific to say outpatient physical therapy, occupational therapy, speech therapy. Because obviously there are especially hospital systems and nursing homes that are using things like Epic and Cerner. So I think that could be a piece of it. But I'll be honest, I do know private practices that use WebPT, Clinician, and other therapy specific EMR systems that have this built in, like you said, but then they just don't do it. And they may not do it because of, say, a time commitment. Maybe they just don't want to do it. Maybe because the owner or something has other, quote, productivity issues, that they're trying to address, because obviously, doing those outcome tools can impact productivity because it can take some extra time.
Right. And for us, I mean, we have come up with a system where they end up on an iPad up front. They're done by the evening staff. Everything is up. We even have them on little buttons, that people can just walk in. They hit the code, which is usually the address, right? So for example, Bethesda 6710, Rockledge Drive, they hit 6710, pop in, plug it in. So we've found certain efficiencies there. I think outside of that, net promoter score, and when we've been using churn rate more, it was really challenging to I think really look at churn rate last year and have what we felt like were really accurate metrics. Obviously, just not knowing when people would potentially fall off sometimes with regards to COVID. But I think net promoter score is another one that it really can be incredibly beneficial, especially if you're getting passives or you're getting your detractors, and there are certain things that is triggering with regards to actions or steps that people are taking either clinically or clerically. Do you have something you want to add for that?
Well, it's something you just touched on. Another metric that I think is extremely important that people don't look at, a couple of them, is completion of a plan of care. There are times I go in and out with Josh, what percent of your patients complete the plan of care? I don't know. Okay, well, we probably need to know that. Also, how about, the conversion of referrals? Because I have clients that, say, Rick, we want you to retain you to help us get more referrals. I go, okay, all right. Well, how many referrals are you getting a month right now? 100. Okay, so you're converting all 100 of those? No. Oh, okay. 90%? No. Well, how many? 52%. Okay, your problem is you don't need more referrals. It's just you've got them, because if I can get you 30 more, if I can get you 82 out of 100, you're going to be packed. You're going to need to hire more staff. So people always think we need more referrals, and you might, don't get me wrong, but in this example, you've got the referrals, we just can't convert them to have them come in for an appointment. And why is it? Is it we don't have enough front desk staff to do the calls, or we do the initial call to Josh, we don't get you, we leave a message, maybe the patient calls back, leaves a message for you, you don't get back to them. Can it be an insurance authorization issue that just takes time, and then finally, the patient just gets frustrated, you get frustrated, end up going somewhere else? So I think that's another one to look at for clinics. When you track in your metrics is, okay, you got these referrals, what's your conversion rate? And if you're converting, 80% or higher, to me, that's pretty good. I mean, some may be higher, some may be a little bit lower. Again, depends on where you're doing business at, your patient demographics. Again, not to do stereotypes and that, but your percent of maybe work comp, auto, Medicaid versus Blue Cross, Aetna, Medicare. And again, I'm not trying to judge people. It's just you see differences, of course, sometimes based on patient demographics and insurances.
Yeah, and I think, kind of going back to what you were talking about the referral conversion. Something that we've become more familiar with is the digital marketing side, and we could probably have a whole separate conversation on this. But when you have certain metrics where that person's kind of getting into your ecosystem, recognizing that things like timeliness, certain times of the day where you're calling people back, having some kind of tracking system for what gets done. Some of these are extremely, extremely important. I don't think that people are thinking about them a ton when it comes to healthcare. And I think you would probably agree. I think the business practices in healthcare largely are probably immature when it comes to, if you were comparing industries across our society. So hopefully these are things, and I know you've been doing a great job. For anybody out there, we've been using Gawenda Seminars, the Gold program, I think for about 2 years. I was dabbling in, I forgot, was there an unpaid version or a less version?
Yes.
It was very beneficial. We were not to the point where we just recognized the value of the Gold subscription, but we're extremely appreciative, obviously, of all of the information and the wealth of knowledge that you or anybody else that's contributing to that is providing people.
Well, thank you. And something I just want to add, obviously you asked how I got started. Even when you went to PT school, I don't think you dreamed that you'd be doing what you're doing right now. I think we all go to PT school because we want to treat patients in some setting. And then some of us want to move into hospital administration or nursing administration. We want to start a private practice. But yet we don't have the business degree. We don't have the business background. We don't have a marketing degree, a marketing background. We don't have a human resource degree, an HR background. And those are all things that go into running a successful private practice. And I'll be honest, one individual can't do all of it. And I get it. What I'm going to say next is I know when you're starting a private practice, especially if you just come out of school, you're 6 figures in debt, you don't know what you're doing, you're trying to make ends meet, and you don't want to pay a consultant. I don't care if you pay me, I don't care if you pay Josh or somebody else or be a member of APTA, but I'm going to be honest, it's better to pay somebody early on it's going to make you way more money down the road, and it's going to save you hours of headache sometimes. And, obviously, I'm sure, Josh, you spend a lot of time on social media. It's like Twitter, and I've been on a lot of Facebook groups, and, I try to help people out, and you answer and all that. But I do want to be clear. Facebook will not solve all your problems. Twitter will not solve all your problems. Also, be careful what you post about, don't say things of what you're doing that maybe shouldn't be on social media. Again, that could be a whole different topic. I'm just on a tangent right now, but
especially after the past year, Rick, and I know we've had our conversation surrounding productive dialogue or sometimes productive discussion. And that's a way of kind of gingerly kind of maneuvering around some more inflammatory ways of describing some of the things that go on social media. But not to get too far away from our business talk, focus on business literacy. It's one of those things where I think, I mentioned earlier, this is a 4-letter word in PT. It's a 4-letter word in healthcare. And when you see something like what happened a couple of weeks ago with regards to ATI going public, you see an automatic response from certain people. There are almost just walls put up where we view them in this manner. They are all about X, Y, and Z. And I think sometimes people miss opportunities to learn because at the end of the day, they've had to have done something right or multiple things right, to be honest. You might not like some of the things that have gone on. And I'm sure we could sit here and say, hey, we'd like to see this improved or focused on. But when people get into this argument sometimes about quality care and then they fail to utilize or show things through metrics, and you're just getting into this subjective argument about, oh, well, my private practice is better because we're one clinic versus 900. Well, we need to do a better job of getting out there and communicating and showing that difference. But with ATI, I mean, can you share a little bit of what it means to go public and maybe your superficial understanding of their trajectory to get to this point?
Yeah, I mean, obviously they're not public yet. That's going to be probably the next step since they just took on another investor. Obviously I came out a couple of weeks ago. I want to say 2-3 weeks ago.
Yes,
I think they're being valued, projected about 125 million EBITDA, and I think the money that's being invested into ATI is $2.5 billion. So when you kind of take 2.5 billion divided by the 125 million, you're looking at close to, I think, a 19 multiple in there. Obviously right now, the one therapy specific company that is public is USPH, and they've been public for a while. You have Select Medical that's also public, but they're just not therapy specific. So we do believe ATI, we believe, will be the next one to go public on the stock exchange. And, and there are other therapy chains probably coming up behind them, whether it be Athletico, you got Pivot, you got, quote, Benchmark / Upstream, and there's probably more, coming behind that. And I get it, obviously, because my wife and I and another business partner, we own 2 clinics here in California. Many of my clients are what I call the small mom and pops. It's just the owner, maybe another therapist, and they've got 1 clinic, or it's an owner with 2 or 3 clinics. That's, I do cater to them. I also do big chains as well. But like you said, I think the one thing ATI and Athletico and Benchmark and other companies out there, because they are so big and they've got the money behind it, is I think they have the outcomes. They spend lots of money, to make sure they've got the outcome data, whether using photo or just any of the other tools you mentioned. And because they've got all this data and they've got the resources to put it all together, I think that and they also can go into a certain state or geographic region and have lots of clinics where now they've got that, quote, power, so to speak, or the buying power to go to these insurance carriers and, quote, demand better payment, demand revised contracts, because they can show the data that they have in terms of patients getting better, hopefully less visits, less dollar amount per visit. But if you control the market and you just basically say, oh, you know what? We don't like this price. We're not going to take the contract. And I'm just going to say, insurance A, then what are they going to do? Because obviously they have to have so many providers of physical therapy in a certain area to take care of their clients. And that may force them to pay more, to that. So you got to remember, whether it be ATI, Athletico, and again, I'm not endorsing any companies, okay, Golden Bear, etc. They all started out as a physical therapist opening up a private practice. The ones I'm mentioning. And then they went to a second clinic, a third clinic, a fourth. And some of them, they opened up brand new, what we call it de novo. Or they could, then they go maybe purchase a couple. And then they've got 10 clinics, 12 clinics, 13 clinics, whatever it may be. And then you kind of maybe then these private equity groups come in and, see the growth of the clinic, see the rehab potential of the clinic. When I say rehab potential, I'm going to be honest, private equity, they want to make money, but they also want to make sure they're giving good quality care and all that, because if you do get a bad reputation, private equity could lose the money, because if you're not making money and increasing visits and improving income and all that, there's a risk to that as well. So I think, it's envy and jealousy can be very damaging at times. And hey, all those individuals, they took the leap of faith, they started the practice, and they built it to what it is. And, it's going to keep on going. Do I think, my opinion, 10, 15, 20 years from now, do I think there's still that potential for that therapist that's graduating in 2041 to open up a private practice? I would say so. But, who knows? Who knows what the market's going to look like, 20 years from now?
I always sit there and go, well, if I don't like this, or if I don't like how this is being done, I need to learn how to play the game in order to change the game. And I think too often I will see people automatically lose that learning opportunity or an opportunity to just sit back and reflect and go, all right, well, if I'm not enjoying this as a part of our profession, how can I potentially change the narratives there? So, I don't have a full picture of what goes on at ATI, but it is always interesting to see on social media and hear sound bites and stuff like that. And we're in an incredibly fragmented profession, right? With regards to the amount of small bit, one, you don't have a ton of really, really big groups.
Keep in mind, ATI has provided an income for these small mom and pops because, ATI, obviously they can start the news sites, of course, but when they're purchasing, a clinic or two from an owner, did that clinic owner not profit by ATI, in this example, ATI purchasing them? So again, that owner that sold to ATI, why did they sell? And did they do it for financial reasons? Did they do it because ATI can help them grow? They can open a third clinic, a fourth clinic. They're going to help with the marketing. They're going to help with HR. They're going to help with retention. They're going to help with hiring and all that. So, people may be, quote, mad at ATI, mad at Athletico, et cetera. But if nobody's selling the clinics to ATI, Athletico, they're not growing. You can't be mad at them. So I think it's a two-way street. It's like a marriage. It's give and take between the husband and the wife.
Right. And when we talk about, you talk about like a clip or a phrase, so to speak, like a sound clip or phrase, economies of scale. And I look at sometimes, you have economies of scale and there could be tremendous benefit. I think if I'm looking just at my ability to take care of my own people, talk about being potentially enveloped up into a bigger entity where reimbursement's better, right? Yeah. You could have better salaries and most likely benefits for your team.
Too, yeah. 401k, maybe, a lot of small practices may not do a match.
Right.
These bigger companies are doing, say, a 3-4% match.
Right.
Obviously, usually their health insurance is better / quote more affordable. Vacation time, paid time off typically is better.
Right.
So you do have to look at kind of those things as well.
Right. It's all considerations. And I do think the more that we really comb through things that are occurring in our industry and appreciate that there's probably some good and some bad. It's not all bad or all good. I think the
Correct.
more that we'll learn from opportunities like this and ideally continue to play our part in terms of moving the profession in a direction that we want to for the future. So.
Yep.
Just a final thing that I do want to dive into. I know there's some new things going on with regards to Medicare Advantage plans, some things that you've been doing a great job of getting out there and communicating to people. Honestly, some of the stuff, even myself and my team needing to get better educated on as well. But can you just kind of kick things off there?
Well, I guess let's go Medicare Advantage because, obviously I spend a lot of time on social media and stuff, and especially on these Facebook groups. And probably, one of the most common mistakes I'm seeing being made is there's a lot of therapists in private practice that are out of network with Medicare Advantage plans. And because they're out of network, they think they can just charge a Medicare Advantage patient whatever they want. So again, when I say Medicare, that's traditional Medicare. Medicare Advantage is something completely different. And with Medicare Advantage, if you're not in network with those Medicare Advantage plans, it's going to really be one of usually two options. So with Medicare Advantage, that patient can either have a Medicare Advantage HMO plan or a PPO plan. Now, most times, if they have a Medicare Advantage HMO plan, typically those plans don't have any out-of-network benefits. So if they don't have any out-of-network benefits and you're not contracted with that Medicare Advantage plan, then you can charge that Medicare Advantage patient your fee, whatever it may be, and they are financially responsible for your fee. However, my experience, most Medicare Advantage patients have a PPO plan. And many of those PPO plans have out-of-network benefits. So if they come to you, you tell them, well, Josh, I'm not in network, but you have to get their insurance information. You have to call that insurance plan. If they don't have out-of-network benefits in a PPO plan for some reason, then you can charge that patient whatever you want. They're financially responsible for your entire fee. However, most have out-of-network benefits. You then have to ask the person on the phone, okay, what's your process for submitting claims? And you're going to be limited how much you can collect for that visit based on the combination of what does the Medicare Advantage plan pay you and what is the cost share and responsibility of the patient. So you may charge $200 for a visit. Say you charge $50 per unit, you do 4 units, $200. Well, I've had people I see on Facebook, they're telling people on Facebook, they're posting this, that they collect the whole $200 up front. They give the patient a quote super bill, and whatever they get paid back, they get paid back. Well, that could be illegal if they have out-of-network benefits. Because if they have out-of-network benefits, let's just say your charge of $200, let's just say the insurance company says, well, the allowed amount is going to be $120. The insurance, will pay 70% of it. So the insurance will pay $84. The patient pays the other 30%, which would be $36, which is $120. That other $80 you just write off as a contractual write-off. So I see people doing that the wrong way because they just think, well, I'm out of network, doesn't apply to me. But this is Medicare Advantage, and it's different if they have out-of-network benefits.
Got it. Yeah. I mean, that was something, honestly, after we just had a brief conversation over the phone that I had our team look back into. I know that there are things that are just changing every year. Obviously, there were cuts that were even in play recently that we had to do our best to advocate for. I know that those are probably still coming down the pipeline here. Just to wrap things up today, what recommendations would you have for anybody who's out there who maybe is, trying to be mindful of upcoming payment cuts? They're in a position where they're in a business, or maybe they have control over, services being provided, or new programs or growth in one respect or the other.
Yeah, just to touch on the upcoming payment cuts. Obviously in 2022, we've got Medicare, Humana, TRICARE, and United Healthcare are all going to pay services done by a PT assistant or an OT assistant 15% less because of that CQ modifier for PT assistants, CO modifier for OT assistants. So you've been using those two modifiers since 2020 for Medicare and some of those other insurance companies. Does not affect payment until 2022. My opinion only, you're probably going to see some other payers jump on that same bandwagon, like Aetna, Cigna, the Blues, etc. Number two, obviously we did avert the 9% payment cut in 2021 under Medicare. It only went down about 3.3%. Unfortunately, in 2022, some of that comes back, and about another 3% that comes back. So if Congress doesn't do something by the end of this year, Medicare is going to go down another 3.5% on that. And then keep in mind, there are other insurance carriers that base their payment for therapy on the Medicare physician fee schedule and what they pay. So if the fee schedule goes down under Medicare, could that put other insurances' fee schedules down as well? So, that's something to think about. So in terms of then, how do you look at all this stuff? I'm going to be honest. I know it's this bad word called productivity, but I think it is something we do need to look at. Obviously, I'm sure, Josh, therapist salaries have risen greatly. When I graduated way back in 1991, my first job was like $14 and maybe 50, 60 cents per hour. Now here in Southern California, we're paying new grads in a private practice setting 37, 38, 39 per hour. And of course, I'm sure you hear the same thing. They need the money because they've got 6 figures worth of debt because of PT school. But, productivity, we have to look at. Now, it can't be the sole factor in, quote, how you treat patients and schedule patients and all of that. But we have to look at the units per visit, units per 8-hour workday. Are we doing the quality CPT codes? And I think an easy fix is there are many times I go and analyze practices, and I'm going to keep math simple. Let's just say in a month they build 1,000 units that month. Well, it's not uncommon for me to see that 700 of those are therapeutic exercise, 100 neuro-rehab, 100 therapeutic activities, and then another 100 just miscellaneous ones. And then, of course, I ask you, Josh, do you and your staff, you guys do functional stuff? Oh, yeah, Rick, all the time. Josh, you work on balancing it? Oh, yeah, all the time. Well, Josh, define all the time for me. Oh, Rick, if we have an hour session, I guarantee you at least 30 minutes of it we're doing functional activities. We're working on balance and posture and proprioception. I'm going, okay, Josh, well, one of two things. Either you're lying to me or your staff doesn't understand the CPT code differences. So, and I think that's where we do leave money on the table. And again, you never charge a CPT code because it pays more money. Right. You charge a code that best describes what you're doing. But under Medicare, therapeutic activities pays between $8 to $9 more per unit than exercise. Neuro-rehab pays about $4 more per unit than exercise. But if you look at your other insurances that pay on a per CPT code basis, they probably do the same thing. So can you increase income without even increasing a billable unit? You could if this is what you're doing wrong.
Yeah, I think when I think of that, it's like the insurance company's already telling you what they value, and you're just listening to them with regards to what they value. So after that, you're just trying your best to deliver a session of a certain time frame. We can't say specific time, but if you're delivering a valuable session, we could probably argue that there are certain time ranges in which those sessions are going to be delivered as well. But yeah, I think too often people And I've heard, negative situations where people have kind of gone, hey, this is what we're billing for every Care First, or hey, this is what we're billing for every Aetna. This is the way to maximize it. Obviously, we don't have to go into a conversation about that. That is not the best way of doing things, but coming up with some ranges and some, I always call it, the guardrails. There needs to be a little bit of wiggle room.
Well, I think it's that you educating your staff and explaining, here's what falls under Therex, here's what falls under neuro, here's what falls under therapeutic activities. A couple I see missed: prosthetic training, orthotic management and training. Again, it's just educating the staff what falls under there, how to document if that's what you're doing. I also think, there are some clinics that just apply Medicare's quote 8-minute rule across the board to all insurance carriers that don't follow the 8-minute rule. So again, might they be leaving money on the table with those insurance carriers by doing that?
Yeah. And honestly, the CPT code talk of yours really hit home. I don't know if you remember this. Obviously, I remember being in Hunt Valley and sitting in my seat and having you deliver your presentation. And after that, we definitely did a lot of things differently. But for people that want to learn more about Gawenda seminars or the recent M&A group, or honestly, some of the speaking gigs, because I know I feel like you're at every single event speaking on something. But for people that want to stay connected with you or learn more, where are the best places to do that?
Yeah, well, I'll see my website. So if you go to www.gawendaseminars.com, so it's GAWENDA seminars.com. You can look at all my information out there. I typically publish about 3 to 4 articles a week under current news. So if you, again, as Josh said, if you're a gold member, you get the entire article with all the resources, the links, etc. I also have a lot of what we call frequently asked question topics, where as a gold member, not only do you get the question, you get the answers to the questions on topics like the ABN, the PTA, OTA modifiers, telehealth, things like that. If you have, if you are a private practice and you're, interested in, mergers, acquisitions, or you're looking for an exit strategy, my email address is just Rick, R-I-C-K, at GawendaSeminars.com. I'll give you my phone number, 661-645-1490. As Josh said, I'm blessed to get to talk around the country. Haven't done much the last year. So hopefully we'll get back on the road. Hopefully maybe, October of this year. We got the private practice section conference, scheduled of the APTA scheduled for October. Hopefully that will be a go. Just kind of have to wait and see how the vaccines continue to go and COVID around the country. And, hopefully we'll get quote back to normal, where we'll have CSM back up and, WebPT Ascend conference and the private practice section conference. And then, I will probably do some maybe speaking dates, hopefully in fall, where public can come to my seminars to learn about documentation, coding, billing, things like that. And you can follow me on Facebook and Twitter. I don't know if Josh can put that out somewhere, my things or whatever, but I try to put information out there for free as well.
I will definitely tag you in that stuff. So when this gets posted live, everybody will obviously have his handles, particularly on Twitter. But I can say he's very responsive. I know that if you look at everything that he has going on, that obviously he is very, very busy, but he does make time for people. So feel free to reach out. And as I mentioned earlier, I think our profession as a whole could do more just with regards to bringing up their baseline knowledge of how the business of healthcare works. And he is definitely somebody to lean on there. But Rick, I can't thank you enough for making time today. I'm sure we'll stay in touch. was writing a couple notes and thinking of some questions that on another time I would like to ask you, but thanks again.
Oh yeah, no, thanks Josh for having me, reaching out, enjoy it. And hey, I think you and I could probably do these monthly almost for people, but I look forward to hopefully you and I getting together again on here, but also seeing you live in person somewhere. So thank you very much.
Yes, definitely. Appreciate it again, Rick. Thank you.
Thanks. Okay, bye-bye.